Hi, my name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News. Well, we have an exciting new installment of our webinar series for you, and the topic is menin inhibition for the treatment of acute myeloid leukemia. The treatment of AML has certainly been a tough nut to crack over the years. We have seen the mysteries surrounding the biology of this disease come to life, resulting in the development of new therapeutics that seem promising in early phase trials, but ultimately fall short of their promises in improving the survival of patients with this aggressive blood cancer. Wet ink was laid to paper for the first publication of the mainstay treatment, 7+3 induction chemotherapy, in 1973. And although effective, this one-come-all therapy certainly has its shortcomings. And the modern promise of targeted therapies has worked to improve on these outcomes for our patients. However, it wasn't until the approval of midostaurin in 2017 where we took our first steps towards that new future. Menin inhibition is generating a lot of excitement in the field and is looking to take the care of patients with AML along that next step in the path towards personalized medicine. Well, we have a wonderful lineup for you for this webinar, including our moderator, Dr. Sekris, as well as panelists, Dr. Michaels and Dr. Stein. Now let's begin the webinar.
Well, welcome everyone. I'm Mikhail Sekris. I'm Chief of the Division of Hematology at the Sylvester Cancer Center, University of Miami. And it's a real pleasure to introduce this webinar on menin inhibitors. I'll be moderating this webinar, and we have two all-star leukemia doctors who are going to be discussing menin inhibitors. Let me toss it to Laura to introduce herself.
Thanks so much, Mikhail. Yeah, I'm Laura Michaels. I'm the Chief of Hem-Onc here at the Medical College of Wisconsin and a leukemia clinician and clinical researcher. I'm very happy to be here.
And I'm Eitan Stein. I'm the Chief of the Leukemia Service at Memorial Sloan Kettering Cancer Center in New York City. Also very happy to be here.
Great, thank you both. And the three of us know each other very well, and that's why we're addressing each other by first names. But if either of you would prefer a last name, you can pivot to that as well. We are talking about menin inhibitors. These have been so in the news in ASH Clinical News, and we've seen a bunch of abstracts at the annual meeting at ASH. We've seen a bunch of publications. And a lot of people are really excited about this and thinking that this may be one of the next approved lines of drugs to treat acute myeloid leukemia. So we wanted to dive into this topic. And I'm going to start with some basics, if that's okay with both of you. I'm going to ask a really easy question. What are menin inhibitors and how do they work? Maybe I can ask Dr. Stein to start us off on that.
Sure. You know, it's an easy question that's got a tough explanation, but I'll try to do it as simply as possible. So I think it's been known for some time that when we think about acute myeloid leukemia isn't one disease. It is one phenotype, but there are many, many different molecular and genetic alterations that can lead to the development of AML. And everyone who's listening to this call probably knows that we now have targeted therapies that target IDH mutations and FLT3 mutations. And these are things that have already entered clinical practice. So there are two subtypes of acute myeloid leukemia that seem to be particularly dependent on an interaction between a protein called menin and a complex called the KMT2A complex, previously known as the MLL complex. And what menin inhibitors do is they block that interaction between the protein menin and the KMT2A complex. And this is particularly important in two specific types of or subtypes of acute myeloid leukemia. One is acute myeloid leukemia with KMT2A rearrangements that occurs in about 5 to 10% of patients with AML. And the other is for patients with nucleophosmin or NPM1 mutations. And those mutations occur in about 30% of patients with acute myeloid leukemia.
Yeah, that's a great explanation, Eitan. A couple of other things also is, it's one thing to remember is that the scaffold protein is actually part of a bit of a differentiation block. And so one thing about interrupting that with an inhibitor, you have to think about, then you're going to get differentiation. And at least preclinically, if I'm not wrong, Eitan, preclinically, one of the bigger concerns was the differentiation syndrome with those inhibitors, although it hasn't quite played out that much in the clinical trials, if I'm right.
Yeah, so that's exactly right. That in the preclinical studies, this drug acts like a differentiation agent, or this inhibitor does, like you would see with ATRA and with IDH inhibitors, and to some extent with FLT3 inhibitors. And in the clinic, I think we are also seeing a differentiating effect rather than a cytotoxic effect when this drug is, or these drugs that are being developed have been given to patients.
Right. The other thing that's interesting is that there's actually a lot of other subtypes of leukemia that may have some upregulation of menin, or where they're looking to see if menin inhibitors could be helpful. This is they're looking at, for example, I think there was something in the New England Journal about a rare pediatric subtype that it is dependent on this interaction. I know I also read that there is some work being looked at ASXL1 mutated AML, EZH2, that there may be other subtypes other than these larger groups. But Eitan's totally right. When we're thinking about the groups that are initially being targeted, it's the about 30% of AML that's mutated NPM1, and then a bit smaller percentage, 8 to 10%, that have a KMT2A mutation. At least that's in the AML group. There's also, of course, studies going on in acute lymphoblastic leukemia and undifferentiated leukemia as well.
So, Dr. Michaels, if we're thinking about patients who have KMT2A mutations, just for the folks who may be listening who don't practice acute leukemia every single day, or who are earlier in their careers and may not be thinking about it as much, what types of patients are more likely to have a KMT2A mutation? So patients walk through the door, we rush to get a diagnosis, and we wait for molecular mutations to come back. Is there a type of patient where you would be more suspect of a KMT2A mutation based on risk factors or disease presentation, or a patient who's more likely to have an NPM1 mutation?
So I've been corrected before when I've used the term KMT2A mutation. It's really a KMT2A rearrangement, if I understand things correctly, which is, so that block of patients is one that's historically been very high risk group, and high risk, they can often get into remission, but a high risk of relapse. Depending on which of the rearrangements that you're looking at, there's a sort of hierarchy of likelihood of relapse and how quick it is. But it's always been one that we've thought about in a higher risk category, most of those. I don't think there's anything necessary. Sometimes they have a higher white count on presentation. I'm not sure if there's other particular a priority markers that would say this. In terms of the NPM1 mutation, that's something we've seen in a normal karyotype. So it's something that, if you've got if your fish comes back without a mutation, then your likelihood of it being an NPM1 mutated goes up. If you're looking at all comers for AML, about 25 to 30% might be NPM1 mutated. If you're looking at just the subtype of normal karyotype, the likelihood is higher. It sometimes can go alongside FLT3 as well, the NPM1 mutants. In fact, some of these trials will have to sort of categorize, are you going to prioritize putting somebody on a FLT3 inhibitor or an NPM1 inhibitor, for example. I don't know, Eitan, anything else you think about when you first meet a patient where they might have either KMT2A rearrangement or an NPM1 mutation?
Yeah, so I think for KMT2A, I'm suspicious a patient may have a KMT2A rearrangement if they've received prior cytotoxic chemotherapy for some other tumor. Usually it's breast cancer or lymphoma, and especially if that patient ends up having sort of a monocytic leukemia, because a lot of the KMT2A rearranged leukemias end up being monocytic. That's something where I'm looking to my cytogeneticist and I'm saying to them, you're going to want to look for this rearrangement because there's a high clinical suspicion that it might be there. So NPM1 is a little bit tougher, like you said. I mean, it tends to occur more in younger patients. The white count is sort of variable depending on whether you have a co-occurring FLT3 mutation. And there are patients, just to go back to KMT2A, who have de novo KMT2A rearrangement. So it's not only in therapy-related acute myeloid leukemia. There are a subset of patients that, for reasons that are a little unclear, end up having sort of de novo KMT2A rearrangements.
And so that's great, right? I think one of the games I love to play with residents and fellows is name that leukemia. We try to figure out what type of leukemia someone's going to have before the bone marrow biopsy comes out. We can start to, think about treatment and get the treatment lined up when that happens. And certainly folks who've been exposed to, for example, topoisomerase inhibitors previously, have a short prodrome, and if all of a sudden they pop up with an acute leukemia, you wonder if it could be what we used to call the 11q23 or MLL, and now, of course, the KMT2A rearrangement, and never again will I refer to it as a mutation. And I want to know the name, Laura, of the person who corrected you, so I can give the correct lineage to that correction. So can you give us a sense of a little bit of the history of drug development in menin inhibitors? Where did we start? And it seems like there's a lot of hype and a lot of enthusiasm about these. What got people so excited about them? Maybe I'll ask Ethan to start.
Yeah, so I think a lot of the excitement actually started, I think it started probably about probably 2 decades ago. And what the problem that people were trying to solve, or scientists were trying to solve, is how do we improve the outcomes of patients generally with KMT2A rearrangements? Because especially for those who are pediatricians, there's a specific subtype of acute lymphoblastic leukemia that occurs in infants that different than all of the other types of acute lymphoblastic leukemia in children. Actually, these kids or these infants actually have a poor outcome. And these are infants who have this 411 translocation or 411 KMT2A rearrangement. So it was the desire to solve the problem of leukemias caused by KMT2A rearrangements that led to elegant basic research to discover the components of the KMT2A complex that were required for leukemogenesis. A number of years ago, we actually published a paper with a different part of that complex called DOT1L, where we inhibited DOT1L, where that actually didn't work. But at the same time, a variety of folks, probably most prominently Scott Armstrong in Boston, was working on understanding. He knew that menin was somehow involved with promoting leukemia in these KMT2A rearranged patients, but didn't completely understand how that worked. He worked that out in the laboratory, and then using a variety of genetic methods like genetic knockdown and then subsequently small molecule inhibitors, was able to sort of disrupt this menin KMT2A interaction. And in the mice that were ultimately treated in the lab, their survival was much better than what you normally see in survival curves of mice, meaning the mice seemed to be cured and lived forever rather than, having 3 more days of life than the control mice, which is unfortunately what you often see in some of these preclinical
And that was in
studies.
the menin knockdown mice, right? Where they could basically bred mice that didn't have that particular menin. If I remember correctly, also that menin is an important protein in the endocrine system as well. Multiple endocrine neoplasia, I think, is one of the mutations in menin that you can see as a germline mutation.
Interesting. So then talk a little bit about the first trial in humans of menin inhibitors and how those went.
I think the phase 1 was studied and published in 2023, if I remember correctly. And that study was the first in human, and that particular agent was being used, was initially studied for safety and efficacy with a dose ramp up. And from there, it's gone from the phase 1. Now it's in phase 2 expansion, and there's been a number of additional menin inhibitors that have been that are being worked on. But that first one, well, Eitan, I'm going to defer to you. We weren't on that study, but if I remember correctly, the cohorts ramped up pretty rapidly.
Yeah, so it's actually interesting. There were two compounds that were sort of neck and neck in getting into the clinic. One is a compound which is now known as ziftomenib, and one is a compound which is known now as revumenib. And I believe ziftomenib actually entered the clinic slightly before revumenib, although it may have been just around the same time. But the revumenib study, for reasons that are not entirely clear, seemed to move, at least initially, a little bit faster. So the revumenib study was the one that was published in 2023. And as Laura was saying, it was a dose escalation study, but there were two different cohorts because the revumenib actually has an interaction with CYP3A4 inhibitors like voriconazole or it's a substrate of CYP3A4. So when a patient is taking an azole, as many of our patients are for prophylaxis against fungal infections, it changes the pharmacokinetics of the drug. So there were two different cohorts that were investigated, one in patients who were on strong CYP3A4 inhibitors and one in patients who were not on strong CYP3A4 inhibitors. A dose was found for both of those cohorts. And as Laura said, it then moved into a phase 2 pivotal study for patients with KMT2A rearrangements and is actually now sitting in front of the FDA and undergoing review as part of a new drug application. I'll say one more thing. So the other drug, ziftomenib, the company that makes that drug called Kura Oncology, they sort of pivoted at the beginning of the study into leaving KMT2A rearranged leukemia a little bit on the side, and they have been focusing primarily in their early study on nucleophosphate or NPM1-mutant patients.
So the pivotal study that then came from that phase 1 was called the Augment 101 study. The data from that was presented in December of 2023 at the American Society of Hematology, and I think was updated recently at EHA as well. And so that study had a cohort of AML that was either KMT2A rearranged, I'm going to forget.
Or NPM1-mutant.
And then it had a cohort of AL.
The pivotal study only has KMT2A rearranged.
Got it. Okay. Yeah. And it has an AML cohort, an ALL cohort, and then it has a third cohort that hasn't been looked at, which is the NPM1 mutant cohort, and that hasn't been reported. And I think they were all relapsed refractory patients, up to 3 lines of therapy, with a result that looked about 25% CR/CRh in what was presented, and pretty manageable toxicities based on what was presented in December of 23 and updated at EHA.
Yeah, and I think the thing that's interesting about all these, so there are a number of menin inhibitors that were presented at EHA. The one you just mentioned, the Augment 101 data, by the time folks are watching this webinar, should be published, and for KMT2A rearranged patients. But at EHA, there was data from Sumitomo and from Janssen, which also have menin inhibitors, in addition to the Kura compound, which was presented, I think, last maybe at ASH 2023. And what's interesting about all the drugs is that the overall response rate seems to be about the same. It seems to be around 60%, while the rate of CR/CRh seems to be around 25%. So there is this difference between the overall response rate and the CR/CRh rate. I think the differences between the drugs that I've seen so far have been primarily in the toxicities. Revumenib can cause QT prolongation. I don't think some of the other drugs do that. There have been some other small differences between the drugs, but in terms of efficacy, I have not seen any major differences between the compounds with the early data that's been presented to date.
And I think that differentiation syndrome hasn't been a big barrier to keeping people on study from what I was reading. And it may be that we learned a lot with inhibitors for IDH1 and IDH2, for example, about preventative treatments, about early interruption, early steroids. dose reduction with hydroxyurea, sometimes concomitant with the medications. So I think that there's, from what I can see, not a huge signal that differentiation syndrome is a barrier to moving the drugs forward.
So if I could jump in, I think there's a lot to think about with what you two have both discussed with these trials that have led to all this enthusiasm and in fact may lead to approval of these drugs. So let's pause for a second because there's a lot of data that you two both gave us about these really exciting trials, and one in fact which may lead to approval of the drug, which would then go into a label. And I bet there are a lot of people who are thinking to themselves, gee whiz, who would I prescribe these drugs for, and what kind of real response can I expect in my patients in the real world? So let's start with the eligibility criteria. These had to be patients who had acute myeloid leukemia or acute lymphoblastic leukemia, who received 3 lines of therapy previously. Can you get?
I think that they didn't have to receive 3 lines of therapy. It was anyone who was relapsed and refractory, but the median number of lines of therapy patients who went on study received was 3.
So let's play that out a little bit. If I have a patient with acute myeloid leukemia and I gave them azacitidine and venetoclax for treatment, and let's say they received, we'll kind of go with the averages of this, about a year of therapy, right? Would that have been enough to then treat them with a menin inhibitor on trial, or would they have had to have received another line of therapy before they went on to a menin inhibitor?
They would have been eligible for the study.
Okay, so someone receiving azacitidine and venetoclax, either it didn't work for them or it stopped working, could then go on to a menin inhibitor as a single therapy.
Correct.
What about somebody treated with traditional 7+3 therapy in the hospital? Is that someone who could have just received 7+3 once or twice as induction therapy and then could get a menin inhibitor, or did they have to have received post-remission therapy as well?
If the patient had primary refractory AML defined as 2 rounds of induction without a response, then they would have been eligible for a menin inhibitor. If the patient had gone into remission and subsequently was going on to get, once they were in remission, they're no longer eligible for the study because they wouldn't be relapsed or refractory at that point.
Okay. And what about somebody who had ALL, acute lymphoblastic leukemia? Is that someone who has to have received the entire series of hyper-CVAD or have been treated with an entire series of the ECOG study that included blinatumomab? Then that regimen fails them to then go on to a menin inhibitor, or could they just have received a couple of cycles and pivoted to a menin inhibitor?
They would have had to receive a couple of cycles been refractory to treatment. So it's only patients who are refractory to treatment. Patients who are in the midst of their treatment, they would not have been able to go on a menin inhibitor if they had achieved a remission and were sort of just chugging along with their very complex ALL regimen.
Okay. And then in terms of overall response rate versus CR/CRh, can I assume that overall response rate included my favorite endpoint, morphologic leukemia-free state?
Yes.
Okay. And so if you were sitting in a room talking to a patient, what response likelihood would you quote that person? And I'd love it if each of you could answer that.
So for patients who are eligible for an allogeneic stem cell transplant, I tell them as follows. We are trying to clear the blasts from your bone marrow. What typically happens with this particular class of drugs is that the blasts go away first, and then ever so slowly, your blood counts will improve. However, because the durability of response is relatively short, once we get that blast clearance, and once we see no evidence of measurable residual disease, if we can get there, we're going to try to get you to a transplant as soon as possible. And that's sort of how I frame it for them. I also tell them that the rate of true complete remission or complete remission with partial hematologic recovery, CRH, is 25%. So if they are not eligible for an allogeneic stem cell transplant, we are really trying to get them to that CR or CRH, because those patients seem to have a longer duration of response than patients who have a lesser category of response.
Yeah, so I mean, Eitan's making exactly the right points. The first is that, the durability of for those who did get into response, it wasn't long. It was 6.5 months-ish. That did allow people to get to transplant in the Augment 101 study. So again, I see this as a way to get to transplant with either blast clearance or even better, getting them into CR/CRH. I think the lack of durability of response, or this shorter response, also speaks to the fact that in the monotherapy arms, at least, we've seen resistance develop, and that those resistance mechanisms are interesting and may speak to the fact that this may not be best used in monotherapy. And I think that's why these drugs are now being tested in combinations as well.
Those were really great answers. I'm curious, when I first saw the late-breaking abstract at the annual meeting at ASH, I looked at the response rates. They seem eerily similar to the IDH inhibitors. Is that a good comparison in terms of the response rates and duration of response and how you might use these drugs?
I think so. I think you should. I think it's similar to FLT3 inhibitors. I think it's similar to IDH inhibitors. I think all of these targeted therapies, at least in these complicated types of AML that are not acute promyelocytic leukemia, there are just so many other genetic events that are going on in these patients that the idea that a single agent is going to reliably produce a cure like you might have with, or a functional cure like you might have with something like imatinib in CML, I think is a pipe dream for most patients. And I agree with Laura that where I think we're going to get the most benefit of these drugs, although again, this is just a hypothesis, will be combining them in earlier lines of therapy with other agents and hopefully standard of care agents.
Well, it's interesting that the chronic myeloid leukemia comparison, of course, is always looming large, because when we have a clinic day and see our patients with all types of myeloid malignancies or ALL, it's always the CML patients who are our well baby checks, right? The highlight of our day, their blood counts are beautiful, they have minimal or no detectable mutations, we see them for years, develop these deep relationships with them. But the dirty little secret about CML, of course, is that it's a one-hit wonder. It's one genetic event that causes the leukemia. So if we fix that genetic event, which we've done successfully with tyrosine kinase inhibitors, then we have people who have a survival that's similar to age-matched folks who don't have a leukemia diagnosis. And we see this rarely in acute myeloid leukemia, right? We'll have the occasional patient with a poor binding factor abnormality, and just that as an isolated phenomenon, they do very well. Patients with acute promyelocytic leukemia, of course, do very well. So you're both alluding to a future where the Menin inhibitors are not given as monotherapy, but in combination with other drugs. Can you talk a little bit about that? What types of trials are out there combining them with other drugs? And what do you think is going to be the next frontier in combination therapy with Menin inhibitors?
So there's a lot of combo trials either open or in the works right now, looking at Menin inhibitors, for example, in combination with cytotoxic induction therapy like traditional 7+3, looking them in combination with the BCL2 inhibitor venetoclax, either alone or the BCL2 inhibitor plus a hypomethylating agent plus a Menin inhibitor in some cases. There's studies that are out there looking at these in combination with traditional inductions or reinduction or salvage therapy, cytotoxic salvage therapies. We might use, for example, with cladribine, Ara-C, plus a Menin inhibitor, for example. What I think is really interesting also is the fact that thinking about these agents when disease burden is actually low. So, for example, there's evidence that some of resistance to the BCL2 inhibitors might be through alterations in the KMT2A Menin scaffold. And so could something like this be used as a chaser for a BCL2 type backbone to get rid of potential resistance in that way? Could this be used as could these agents be used in maintenance or consolidation following allogeneic stem cell transplant, for example? Is this the kind of thing that we should use at the first hint of MRD relapse, of measurable residual disease relapse, rather than waiting for the burden to be higher? You know, the kinetics of resistance often depend on the burden of disease. So there may be, I mean, so these are just kind of thoughts about how to think about this drug in the future. Not all of this is going on, but that's one of the things I think we should be thinking about, is where there are drugs where resistance develops quickly, perhaps those are the drugs that need to be used when the disease burden is lower.
Eitan, anything to add?
Yeah, so I think for the combination studies, what I would warn people about is to not get too caught up in the hype. Meaning, I think what you're going to see is that you're going to see data presented either, you know, at corporate presentations or at ASH showing that, you know, you combine a menin inhibitor with, you know, 7+3 or with aza-ven, and look, the response rates are 100%. But it's not entirely clear to me what you really need to understand, what the specific patients on the study, what the genetic abnormalities were of the specific patients on the study, because there are actually some subtypes of KMT2A-rearranged patients, like 9/11 translocations, that actually often go into remission, and it's relapse that's an issue. And with NPM1 mutations, those patients often go into remission. So CR in and of itself really shouldn't be what we're looking at. We really need to be looking at, you know, longer term endpoints like relapse rates, duration of response, and ultimately overall survival. Similarly, I think there's going to be a understandable desire, once these drugs are approved, to use them in non-approved settings. I'm thinking specifically about in the setting of maintenance therapy after an allogeneic stem cell transplant. And I think if the Morpho trial, which is the trial that randomized patients who got a transplant with FLT3 mutations to gilteritinib versus placebo, I think what it taught us is that doctors should remember the lesson that you got to be humble, and what you think is going to be the truth might not be the truth. And you could potentially do harm giving someone a menin inhibitor in the relapsed and refractory, in the post-transplant maintenance setting. And it really needs to wait, I think, for randomized studies to prove benefit before we sort of just like widely adopt things like this.
Yeah, I agree 100%, Eitan. And the other thing I would say is that it is also exciting to think about a new drug, but all these single arm studies or non-comparative studies, we really do need randomization. So, you know, is adding this to a backbone of cytotoxic really going to bias anything? The only way to know that is randomization. So I do think that there's a lot more to come on these, and the proof is in the pudding.
So with that, we are so aligned in what you both just said. I hope that ASH Clinical News was not hoping for drawing first blood in this, because they'd have to rename it Drawing First Love. So let me, you know, you're going down a certain path, and I'm dying to ask you this question. If the menin inhibitor monotherapy trial had been randomized, and half the patients got a menin inhibitor, and half the patients got a standard salvage regimen. So maybe for acute myeloid leukemia, that would be MET, mitoxantrone, etoposide, or cytarabine, or some other classic cytotoxic approach. Do you think menin inhibitors would have been superior, the same, or inferior?
Well, we'll never be able to know that, Mikkel. I will tell you, as you know, as well as anybody, an average of 3 lines of therapy for a high-risk mutation I don't walk into a patient's room and say, all right, I'm going to give you MEK and you have a 25% chance of CR, CRH. That's, that's tough. And the other thing is that, especially with patients who've already seen chemotherapy, a lot of these people are older. And to put them through a cytotoxic salvage regimen is not straightforward. And especially not when you can't buy that much with a high risk or an adverse risk molecular mutation all the time. So we'll never know until it is randomized, which, will need to happen.
I'm going to go out on a limb, and I'm going to say, so I totally agree, Laura, with what you said. I would just say that I think there's that in that hypothetical scenario, I would imagine there might be a difference between KMT2A and NPM1. I think KMT2A patients, at least in the literature that's been published, when they are relapsed or refractory, it is very difficult to get them back into remission with any sort of standard therapy, certainly if they've had more than 2 or 3 lines. I'm not sure that's the case with NPM1-mutant patients. I mean, I think that certainly for patients who have been in remission for more than a year, they might respond to MEK. Azacitidine and venetoclax, although it really hasn't been studied in a prospective fashion in the relapse and refractory NPM1 setting that I'm aware of, it seems to work pretty well in those patients. So I do think there may be a differential based on, or a difference in survival based on why you're using the Menin inhibitor and for what specific mutational or cytogenetic abnormality.
Yeah, you're exactly right. The other thing is that you have to make sure that the genetic abnormality you're speaking of is that the dominant one, or is there a really chaotic genetic environment for the relapse? And the more attempts at remission you've had, the chances are you've got a more chaotic genetic environment, and the likelihood of a single intervention, a monotherapy intervention that hits one target is going to be less likely to be the case.
Nicely answered. And I like the notion of thinking about toxicity of the drugs. We all tend to focus on response rates and how successful the drugs are, right? Because that's kind of the exciting part of it. My God, we're getting responses in patients who've seen 3 or more lines of therapy in the past. But the tolerability part is a real issue. And it's certainly part of the conversation I have with my patients who have IDH mutations when I'm giving either enasidenib or ivosidenib or olutasidenib to them in a relapse refractory setting. Like, I don't know if it works better than what's out there, but everything that I've seen tells me it's less toxic. So more tolerable.
I also think we have to pay attention to the fact that prevention of differentiation. We have a study here on the J&J drug, and a lot of these patients are on a lot of steroids. And I think I'm not always used to having my myeloid patients on a ton of steroids for a long period of time. And I think we have to do a little bit of rethinking of our infection prophylaxis, et cetera, because having somebody on, I don't know, a high dose of steroids who doesn't have a myeloid compartment puts them at risk for infection. And, it's just something that we've been talking about as a team here that I think we have to consider in all these patients where we're prophylaxing against DS.
And there are infections that we're not used to seeing in patients with myeloid malignancies, right? They become almost like transplant patients with their immune system compromised. Really good point. We have just a couple of minutes left, and if I can ask each of you for 1 minute, talk to me about what developments in the treatment of AML you're most excited about. And maybe I can start with Eitan.
I was hoping Laura would go first. So, while I think we talked about the one that I'm most excited about, I think Menin inhibitors, like you said, Mikhail, are sort of going to follow the path of FLT3 inhibitors and IDH inhibitors, and that we'll see hopefully some approvals in the relapse and refractory setting, and then we'll get exciting trials with standard of care agents in the newly diagnosed setting. And finally, we'll see novel combinations of FLT3 inhibitors with Menin inhibitors and maybe IDH inhibitors with Menin inhibitors. And we'll have to see how that all plays out. But I think it's going to offer really potential benefit to our patients with KMT2A and NPM1-mutant acute myeloid and KMT2A-rearranged acute lymphoblastic leukemia. Some of the other drugs that are out there, if we're talking in general, I actually have gotten excited recently about CAR T cells in AML. I know this is not a popular position, but I think that CAR T cells for a certain kind of patient, that is a patient who you can't necessarily get in to remission, but you've gotten them most of the way there and you want to transplant them, but you just can't seal the deal. CAR T cells that I've seen some data for, they seem to actually, the newer generations do a pretty good job of clearing the blasts from those patients' marrows, and they subsequently can get or will need to get an allogeneic stem cell transplant. Whether this is going to be easy to do in clinical practice, I don't know. Whether it's going to be applicable to more than a small subset of patients, I don't know. But the technology excites me.
Oh, I hope you're right. I really hope you're right. I would love that to play out. What I'm excited about is, and this is sort of full disclosure, I've been working with MyeloMatch, but I'm really excited about national studies that are going to randomize both young and maybe even older patients to intensive versus non-intensive induction regimens with MRD outcomes. I'm very excited about the potential for being able to deploy very rapid genetic and cytogenetic testing so that people can get answers for their patients within 3 to 4 days, which is something that some of us at academic institutions may have a kind of we take that as granted, but to be able to be at a center, no matter where you are in the US or Canada, and be able to get both cytogenetic and molecular readout on your patient's disease within 4 days, I think will be really exciting through the MyeloMatch platform, and then hopefully something otherwise. And finally, I'm hopeful that we can move into it can move somewhere where we're working also on how we deliver the care, so that we understand the best ways to get people through some of these induction regimens, to keep them safe, to keep their infection risk down. I'd like us to be able to roll out kind of SOPs for some of these novel agents in a way that makes it possible for everybody to achieve the benefit, not just those who are treated where we all have experience doing it.
Well, Laura, Ethan, thank you for a really exciting webinar on the future of menin inhibitor therapy in acute myeloid leukemia.
Thank you.
Thank you.
Great, and we're back. Thank you both for a really super program. We all underwent a very quick outfit change also, and I emerged from the witness protection program, so I was allowed to come out from the shadows. We already have a bunch of questions that have rolled in, and I wonder if we could launch into it. So the first question, standard NGS testing without a so-called RNA fusion panel has a tendency to miss rearrangements. Do you suggest that we only use KMT2A testing modalities with an RNA sequencing component before ruling out or ruling in KMT2A-rearranged patients with leukemia? I'll ask Ethan to start with that.
Sure. I can tell you what we do in our practice here, which seems to work pretty well, which is that we fish for our cytogenetics lab will fish for a KMT2A rearrangement. And that's going to pick up the vast majority of the KMT2A rearrangements. We also have an RNA sequencing panel that's sort of part of our standard workup. That might pick up some cryptic rearrangements, but I really think that if you do standard FISH testing, you're going to pick up the vast majority of the rearrangements that are common, such as 911, 1119, 611, 411, et cetera, et cetera.
Yeah, we also start with FISH Pro and use NGS as kind of a backup to that.
Any sense of whether patients with different rearrangements that include KMT2A respond differently to menin inhibitors?
I can answer that. I mean, as far as we know, in terms of translocations, there isn't a huge amount of data, but in the small amount of data that's been looked at, there's not one particular fusion partner that seems to respond better or worse than another fusion partner. I will say, though, that the KMT2A, partial tandem duplications don't, as far as we've seen, they haven't really seemed to respond to menin inhibitors. And preclinically, there's really only one paper and really one model that shows that they do. So I'd be a little bit hesitant to give a KMT2A partial tandem duplication patient a menin inhibitor unless it's specifically outlined in the protocol that's something that's being explored.
Is that because of where the inhibitor fits in the scaffolding, Aitlin?
That's an advanced level question that I'm not sure I have the answer to. I'm not sure.
Okay, yeah. Also, I don't think we know yet. Like, none of the publications have gotten into the details, at least that I've seen, of all the different rearrangements yet. So,
yeah, I mean, there haven't been a ton of patients who've been treated with these compounds yet either. So, this is going to be like other compounds. If this does end up getting approved, it's going to be like other compounds where we have single-arm studies, limited number of patients, and we're going to learn as we start to use them. So, you both talked about differentiation syndrome as you start to use these drugs, the menin inhibitors, this class of drugs. Should we be thinking about the mechanism of action of this drug similar to how we would think about alternate retinoic acid for APL or the IDH inhibitors?
I mean, I do. When I think of differentiation syndrome, I think about pulmonary infiltrates, rash, fevers, sometimes just kind of a percolating something, feeling unwell, and then you have to think about that a little bit. But yeah, I think actually, to me, it's in parallel with the IDH inhibitors more so than ATRA. But I do think that experience with ATRA sort of made exploring this model a little more comfortable for those of us who treat AML. So, I do think you just got to have your alarm bells on. We also have to remember that things like rash, fever, pulmonary infiltrates also happen with infection and other things that happen in AML. And it's, again, I do think that we may see less differentiation in the combinations, just like we have with IDH inhibitors, because people are more cytoreduced by the time they get the agent.
So maybe I'll ask an advanced level clinical question. Is there a patient population where you would admit them because of concerns over differentiation syndrome, admit them to the hospital, as opposed to treating them as an outpatient? For example, patients with high white counts, high tumor burden.
Yeah, those people would be admitted anyway, more or less. If I was going to give somebody, most of my relapse refractory salvage patients, many of them I admit during the first bits of therapy. I don't know if the protocol is called for admission or not.
I think some of the protocols call for you have to get the white count. You have to get a patient cytoreduced with hydroxyurea before they can start on this study. I think sort of the underlying question, though, is there some patient population that we can predict will have rip-roaring differentiation syndrome? And I don't think we have the data for that yet. So I would probably do what Laura does, that, if there's a patient with a very high white count or very proliferative disease, I might admit them just at the beginning.
Okay. I raised it not to be a smart aleck, but because, as we've widely used Ven-Aza, venetoclax and azacitidine, of course, in the trials that led to its approval, almost all those patients were admitted to the hospital when they were treated. And then people started to use the drugs as an outpatient and ran into trouble with that as well. So we should probably be clear in our education, if these drugs are approved, about what the guidelines are for admission versus trying to do this as an outpatient. Another question that came in: since the CR rates are modest with single agent, what is your view about combining these drugs with other agents like venetoclax or azacitidine?
Well, what I would emphasize is sort of what Eitan said in the webinar also is that I think we should be careful about using these in the approved combinations, not just because they're approved by the FDA, using them in other settings or other ways. So I think, especially when, this care is getting complex, and so we should be really, when and if these drugs get approved by the FDA, I think they'll be approved they may be approved in combination, they may be approved in monotherapy, but I will certainly be using them as approved because that's where the safety data is.
Any difference in response to that, Ethan?
No, I think the idea, though, of combining a menin inhibitor with standard of care therapy on a clinical trial to investigate whether it's going to be better than single agent therapy alone is a good one. But just like Laura, I would not recommend, if these drugs become approved, just kind of slapping them on to your standard of care treatment. So there can be unanticipated toxicities, as we talked about, that might actually end up harming the patient rather than helping them.
And of course, we do have an unfortunate history of drugs that were combined compared to monotherapy and found to be no better, but with increased toxicities in AML. So it can't be a foregone conclusion that adding it to something else is going to make the combination is going to make anything better than even monotherapy. Somebody writes in and asks about reviewing the regimens and initial toxicities. So maybe I can focus that question a little bit. What is the regimen that has gone before the FDA? What are major toxicities that you worry about that you would sit in front of the patient and say, this is part of the informed consent, I want to let you know these things can happen?
So revumenib is the drug that's right now sitting in front of the FDA. And when I'm sitting in front of a patient who's going to go on a revumenib clinical trial, and this is what I'll do for patients who, if the drug becomes approved that I prescribe it for, I will talk to them about QT prolongation. Although I think that for a patient, that's a little bit more of a theoretical type of thing because they don't feel it unless, of course, they have ventricular tachycardia, in which case, or fibrillation, in which case they will feel it. But I mentioned that because I think it's a real toxicity, and I spend a lot of time on differentiation syndrome. I found in my practice with IDH inhibitors and other drugs that promote differentiation, patients are, I'm not sure why, but maybe a little bit reluctant to call me to tell me that they're a little bit more short of breath. And sometimes I don't hear about it till it becomes an emergency. So I really spend a lot of time on the signs and symptoms of differentiation syndrome and educating the patient to call us at like the first hint that something might be going wrong.
Yeah, I mean, I agree. Both with the IDH inhibitors, actually FLT3 inhibitors, and we've used this on trial. I talk a lot about differentiation. I also ask people to pay a lot of attention to rash, to, our people, if they're outpatient, are taking their temperature twice a day. They have, every other day calls with a nurse or a nurse practitioner to check in. So, I think that's the same with all leukemia patients. Like if they're outpatient, they need to be very comfortable alerting us to whatever can happen. And I think telemedicine has made some of that easier, like you get like a little pictures in your MyChart of the rash or whatever. But just people need to be very alert. Also, not to take other medicines unless they tell me.
This is that I had my clinic yesterday. I had that conversation 5 times with patients about the alternative and complementary medicines and just keeping us informed. And I think out of 5, we identified 2 that have interactions with other drugs that we're giving. I assume also that you would take the same approach with thinking about QT prolongation here that you might with a drug like arsenic trioxide, where you make sure that your patient's magnesium is always over 2 and potassium over 4.
Yeah.
Yeah.
Same with the FLT3 inhibitors, right? And then also warn them that, they're going to get more EKGs than they thought they were going to get.
Money, right. Someone writes in you mentioned 3 to 4 days for having the KMT2A status back from the genetics lab. Is that the expected lab turnaround time? Some labs may struggle with 3 ellipses following struggle.
I think I was referring to the fact that we're working on opening a national trial that will allow centralized genetic testing. This is that trial I was talking about called MyeloMatch through the National Cancer Institute. At our center, NGS testing still takes a while, takes at least a week and a half to 2 weeks. But we can get KMT2A response back through FISH in 24 hours. So you can often have a hint about KMT2A before you know about NPM1.
Yeah, the same with us. If you talk to your cytogeneticist, often, and they know that it has implications in terms of rapid treatment, they'll usually be able to turn things around for you.
Yeah, we have a rapid in-house NGS panel on actionable mutations that we started about 6 months ago. It's really remarkable. So kudos to our pathologists for doing that. We get test results back in like 2 to 3 days, but before then we were in the 3 ellipses crowd for waiting.
Does that only test actionable mutations?
Like core binding factor with 3, KMT2A we put on there as well, IDH, stuff that would make a difference kind of immediately in a new AML diagnosis. Yeah. I've got a question for you. So I noticed that the FDA's PDUFA date was moved back a few months. Any idea why?
I don't have any solid knowledge why. Presumably the FDA wanted to see more data about something. Well, I guess there are 2 possibilities. Either they didn't have all the data they wanted, or they were just moving a little bit more slowly than they thought they were going to move. But I don't have any. It was funny. I was actually giving a lecture on Menin inhibitors, and at the end of my lecture, I said, and the PDUFA date is September 26, 2024. And about 5 minutes later, I got a text saying it is no longer September 26, 2024. It is now December something 2020. So I'm not sure what happened.
Yeah, I have no inside knowledge.
Maybe, nor do I. I'm just asking provocative questions because that's my job. Yeah, maybe time to the ASH annual meeting. Sometimes those sorts of announcements are deliberate. And we'll see. Well, once again, as I did on the pre-recorded session, thank you both. The really outstanding job educating all of us on Menin inhibitors and your answers to these questions. It's an exciting time, and hopefully we have another tool in our toolbox to treat patients with AML.
Great. Thanks so much.
Thank you so much.
Everyone.
Everyone.